Okay, so we covered the plantar flexion role of the um, for the heel rise test, and now we want to talk about how the extrinsic muscles function within the foot. So here we are looking at a sagittal view of the foot, and we have the tibia and fibula here, the trochlea of the talus here, talar head, subtalar joint, calcaneus, navicular. And what we're emphasizing in this picture is the mid-tarsal joints and the pull of the triceps surae muscle. So we know that the triceps surae muscle is pulling up on the calcaneus, which, if unopposed, can drive the mid-tarsal joint into dorsiflexion. So we know that the metatarsals will rise up. Okay, so it's lowering the medial ungual arch. So we can look at the couple things. We can see that the talonavicular joint here is a ball and socket joint, and the calcaneocuboid joint, which is here, we can see that it's a plain synovial joint. And we know that this is just arrows just emphasizing the fact that because it's a ball and socket joint, it can have this kind of plantar flexion, dorsiflexion, AB and adduction motion, and that motion's occurring around that oblique mid-tarsal joint axis. Okay, so essentially this is these key points. The triceps surae forces tend to lower the arch of the foot, and the talonavicular joint is ball and socket joint, and mobility is important for this foot adaptation. So likely, as we raise and lower our arch, a lot of the mobility that's responsible for that is coming from the talonavicular joint, and hence the importance of the spring ligament, which is like the keystone of the arch, running from the sustainacum tali to the navicular. Okay, so this is a study by Dr. Hauk, myself, and what we looked at here, we want to focus on the blue line, is how much the person's arch changes shape when somebody performs a heel rise. And so the subtalar neutral position here is represented as the line in the middle, and plantar flexion is negative, and we measured essentially the first metatarsal relative to the calcaneus. So, and overall, what we got from that was, how much the arch is raising and lowering, where plantar flexion would be more arch raising and dorsiflexion would be arch lowering. We can see here, essentially, as they were performing the heel rise, as they were flat, they got, a few degrees, up to 5 degrees of dorsiflexion, and then from that dorsiflex position, then when they went in to begin the heel rise, they immediately went into plantar flexion and extended all the way down to about 15 to 20 degrees. And so, overall, the first metatarsal motion relative to the calc, they moved around 20 to 25 degrees total excursion during heel raise for this particular experiment. Now, we repeated that experiment here, and we have some of the data for a single leg heel rise. And what we can see is that for young, at the first metatarsal, moves relative to the calcaneus approximately 25 degrees in young people and about 20 degrees in older people. And then the ankle plantar flexion that occurs during a heel rise is about 32 degrees in young people and about 26 degrees in elderly. So this is here just to make the point that you have about almost equivalent amount of contribution in terms of plantar flexion from the mid-tarsal joint, here represented by the first metatarsal motion, as you do from the ankle. And we had talked about inversion of the subtalar joint to kind of engage the locking mechanism, but surprisingly we don't get a lot of inversion even at peak heel rise when someone's performing a heel rise task. You only have about 1 degree of inversion total. So the conclusion is the forefoot plantar flexion contributes significantly to heel height achieved during a heel rise test. And so subsequently what we want to talk about is how we control the forefoot in terms of trying to get it to contribute to heel height. And so one option is muscle control. And so we're going to use this graph here, which is taken from MRI activation, but it gets at the muscle activations of these deep posterior extrinsic leg muscles during this heel rise task. And what we want to focus on is the red, being the posterior tibialis, the blue being the both the peroneus longus and brevis. And then the gastrocsoleus we'll ignore because we've already kind of covered the plantar flexion function in previous discussions. So if we think about the posterior tib function, we know that the posterior tib runs medial to the posterior of the median malleolus and then extends and attaches to the plantar surface of both the navicular and medial cuneiform. And so by doing that, we know that it inverts the subtalar joint, so it's a subtalar joint inverter. It has an adduction and plantar flexion function at the oblique axis of the mid-tarsal joint, and it also inverts the forefoot at over the longitudinal axis of the mid-tarsal joint. Now the fibularis longus and brevis does almost the opposite. It is a subtalar joint everter. It abducts, and this should say dorsiflexion here, so it abducts and dorsiflexes around the oblique axis of the mid-tarsal joint, and it also everts the forefoot. So we could ask the question, with those different actions, is if we wanted to control where the pressure was in the ball of the foot, if we wanted to bring the pressure during the heel rise task laterally, or if we wanted to bring the pressure under the forefoot medially, what muscle actions would we have to do? Okay, so to bring the pressure completely off the heel and just into the forefoot, what we'd need is for the ankle plantar flexors to contract, okay, to lift the heel up. Okay, but then if we wanted to balance or control where the pressure is, we'd have to bias the foot one way or the other. And so essentially what we'd have to do is accentuate the rear foot inversion, forefoot inversion, and forefoot plantar flexion and adduction. If we did all of those things, we would move the pressure laterally in the forefoot. And so basically, if we look, we can see that the posterior tib activation could successfully do that. If we wanted to shift the pressure opposite, if we wanted to shift the pressure to the medial side of the foot, what we would do is, again, to lift the heel off and relieve this pressure here on the heel, what we would have to do is contract the triceps surae and lift the foot off the floor. And then we would have to use the fibularis longus and brevis to kind of evert the subtalar joint, and then we would we get forefoot eversion from the fibularis longus at the mid-tarsal joint, and then we would also get forefoot dorsiflexion and abduction from the fibularis longus and brevis. So in essence, we can use those concepts to think about some questions we might answer clinically. So if you have a patient with medial ankle pain, when they heel raise, they stay in a hindfoot eversion position. What muscle is compromised? So if we think about this as a muscle balance problem, so here we have the posterior tib and the fibularis pulling. If it's in eversion, one of these muscles is unopposed. So the everter is the fibularis longus muscle. So essentially what's happening is we don't have enough input from the tibialis posterior, so there's not sufficient co-contraction from the tibialis posterior, so we end up at the subtalar joint with eversion. And so the answer to the question is when they heel raise, they stay in hindfoot inversion. What muscles compromised? The answer would be posterior tibialis muscle. Secondly, you ask a person to heel raise and they say they just can't do it. What are some of the possible causes? Well, one would be weak plantar flexors. A second one would be inability to keep the foot rigid during the heel rise task, so they have midfoot instability. And then the third one would be potentially weakness of either the tibialis posterior, which essentially might leave the foot too flexible to perform the heel rise task. So any three of those would be a legitimate reason why somebody couldn't perform a heel raise.